Integrating Mental Health Care into Primary Care by Michael Baker.
Depression is a malady that affects both the brain as well as the body. According to recent estimates, over 300 million people are afflicted with depression alone, which represents an increase of 18% between 2005 and 2015. In addition to lack of support, patients must deal with fear of stigma, which contributes to their failure to seek treatment. These issues prevent many from experiencing fulfilling lives. Lack of resources. Despite the prevalence of people afflicted with mental health issues, this area of care is under-resourced compared with typical medical care. So even when there is not a shortage of providers, patients still have difficulty seeking care. This contributes to patients not having symptoms identified, defaulting to ineffective care, and the subsequent revolving door phenomenon. The term revolving door phenomenon was coined to define recurrent hospitalizations of chronically ill patients after closure of psychiatric hospitals and the implementation of community treatments. Flexible implementation. Managing community resources in a holistic manner, bringing social services, hospitals, clinics, and primary care together. We will need to overcome institutional resistance to change. There are always many changes occurring in all organizations, and change does compete with other change. So sharing decision making with each stakeholder is a good way to overcome that, and it's also important to have flexible review parameters, as each system requires different solutions. One of the challenges affecting mental health care is the stigma that patients feel. So despite recent educational initiatives, there still exists a stigma towards people who suffer from mental health disorders. This stigma reduces the patients that receive appropriate care in absolute numbers. Certain cultures have more stigma than others, such as the Latino community. Potential pitfalls. We need to avoid medicalizing social and psychological problems. Medicalizing is, as an example, where doctors would tend to medicalize manifestations of distress, such as prescribing sleeping tablets for insomnia, where behavioral intervention may suffice. In addition, we need to avoid task shifting, where everybody simply keeps referring them to other places. We need to ensure primary care assesses for psychotherapeutic interventions. We need to promote a recovery-oriented interventions. Acknowledging that clinical education is a continuous process, we need to develop community support protocols to help build partnerships between providers and agencies, and use policy reform to shift mental health care into primary care. We also need to encourage community health care sectors to address the social determinants of mental health. We need the development of guidelines. We have lack of knowledge about mental health conditions by many providers. We need to make these providers more comfortable managing patients with existing mental health disorders, as opposed to establishing new diagnoses. Somebody not trained in mental health care will find that a little bit more challenging, again, due to the lack of knowledge. We also have a lack of guidelines for providers to rely on. There are treatment modalities that are clearly used in medicine that can be different with mental health. Providers need to have that structure to be able to rely on.